Good evening, everyone, and welcome. This is our 10th Women's Wellness Fund event, which is just astonishing to me because it seems like we were here not too long ago, and that was, I think, our second event. I think we have a very interesting topic that we're going to hear about this evening, how women can cope and deal with anxiety and depression during these times. It has indeed been, I think, a difficult time for everyone. I appreciate all of you that have come out tonight to be part of this at our appropriate distances and walking in with our masks, because I think that it's nice to be around people, but I also appreciate I think we have 80 some odd people listening in from home, staying safe as well. So thank you for coming out tonight. For those of you who don't know me, my name is Laura Martino, and I'm one of the vice presidents at Middlesex Health. You know, I think that the work that the Women's Wellness Fund is doing is really important for our community, and I think for just having women be able to come together and hear about topics that are important to them. And I hopefully feel that, you know, all of you feel that the talks that we're having bring value to your life, and hopefully they allow you to have conversations with your friends and your counterparts about health matters that really do relate to women, and know the facts and have good sound information from the whole host of healthcare providers that we've had before you over the last couple of meetings. I'd like to give our thanks to our generous sponsors tonight: Sally Meyer, the Peach Pit Foundation, Hologic, and Liberty Bank. They were very nice to stay with us throughout our process of trying to figure out how we were actually going to still have a program, and we were very committed to trying to make this work. So I appreciate their interest in still wanting to be a part of our event. See if I'm afraid to touch the computer. As I think many of you know, the Women's Wellness Fund advocates for, educates about, and funds priority women's health projects in our community. And you'll learn more about those as the evening goes on. We have a wonderful, wonderful steering committee. They do yeoman's work. We meet on a regular basis. We talk about different topics that we think are going to be interesting to the group. They help us decide where our funding priorities should be. Their names are before you, and I'd just like to give them a round of applause because they work tirelessly for this effort. I also want to thank the members of the Women's Wellness Fund, whose donations through their membership also help to support the priority areas that we fund each year. So now I'd like to ask Sarah Moore, who's our Director of Development, to come up and speak with you about some of those projects that we have funded in the past and some of the ideas that we have for the future. So I hope you enjoy the talk, and thanks for being here.
Hi, everyone. We're going to get to our special guest soon. Sanitize, and that's not working. I'm batting 1,000. There we go. So anyway, I'm really pleased to share that we founded the Women's Wellness Fund in 2017, and since then, you are all members here tonight. Through your generosity, and for those listening in, we've raised $175,000 since then for all these different women's health projects. And I'm just going to walk you through very briefly what we're funding this year. So first, we're investing in technology to better catch women who might be at high risk for breast cancer and refer them to our genetic counselors for further counseling and possible testing. And we're doing that at the mammogram visit. We do 23,000 mammograms a year, so what better place to ask a few screening questions. We're using an iPad and sophisticated technology to immediately refer women who answer yes to any of these screening questions to our genetic counselors for follow-up. So that's one project for this year. The next is we've had a Center for Integrative Medicine and Wellness for quite some time. Right now it's housed at our cancer center, but it's open to the public. It's just a difficult place to find. And so we are relocating it, expanding it. expanding our offerings, and hoping to make it a center that everyone feels welcome and comfortable going to for whatever alternative modality you're interested in. So that might be acupuncture, massage, Reiki, and a whole host of other things. The construction's on hold for the moment, but we hope to resume that pretty soon. And we will report back to our members when that's open and you can take a look for yourself. The third project is a genetic testing study that we are adapting from the Mayo Clinic, and it's pretty pioneering for us. And this again is in the cancer realm, and we are testing whether or not the current guidelines for genetic testing are missing genetic mutations in a cancer. So we are offering this to all patients that are diagnosed with a solid tumor cancer at our cancer center, and offering them a free genetic test if they qualify and are interested. So we are contributing to the science here, and that's pretty exciting. And then finally, we're funding a program that we have funded since we were founded. It's called the Perinatal Social Work Program. And that is women who are really struggling and are pregnant and need extra support, and they may need to get out of a domestic violence situation. They may need housing, they may need food assistance, they may need mental health counseling. We have a social worker, a single person, a point person that all the OBGYN offices and the various social service agencies around our community can refer, and then really connect those women with supports that are out there but they may not be aware of. So we're really happy to support that again. So I'm going to move on to our speaker. I'm really pleased that Cristina Sanchez-Torres could be here. She was going to be our special guest back in March, and we had to cancel that event. That was toward the end of March, an in-person event. And so we're glad to sort of be picking that up. And what better topic to be talking about tonight? So she is our medical director, consult and interventional psychiatry at Middlesex Health. She's also the attending physician for our electroconvulsive therapy program, and she will tell you more about that. She's board certified in adult, child, and adolescent psychiatry, and she's a preceptor for various medical students and psychiatry fellows. Just one note for our folks joining online, we will take questions from all of you here gathered tonight, but if you're online and you'd like to ask a question, please use that Q&A button, and we will keep track of that and try as best we can to get to your questions. So I'm going to turn things over to Dr. Sanchez-Torres. Thank you. All right. Can everybody hear me okay? All right. So just take this off, make it a little bit easier. All right. So just a little bit of background information, just like Sarah said. I am an adult and adolescent psychiatrist, born and raised in Puerto Rico, moved to Connecticut 6 years ago to do my subspecialty in child and adolescent psychiatry. Worked at UConn for an entire year and decided to come to Middlesex 4 years ago. And I love what I do. I love the hospital. I love the mission. And here I am today to kind of move on with everything that is the mission at Middlesex. So like she said, questions at the end. If you have something super pressing, you can always interrupt me. I have no problem with that, but we'll leave questions for the end. And let's get going. So we're going to talk a little bit about what stress is, what anxiety is, what depression is. We're going to discuss how these primarily affect women. When do I get help? We're going to talk about some treatments, some that are FDA approved, some that are holistic in nature and more natural approaches as well. We're going to talk about a little bit about medications, therapies, some other interventional approaches, including ECT, PMS, which is transcranial magnetic stimulation, and ketamine, which is something nowadays. Then we're going to talk a little bit about CBD or the cannabis relatives that are also kind of huge these days. We're going to talk a little bit about the American Psychiatric Association on that. And we're going to talk a little bit about other things. How can we support someone who is struggling? The effects of social media, and then we're going to talk a little bit about everything that we have all been experiencing in the last couple months, and how do we strive for resilience. So does this look familiar to anybody? Raise your hand if it does look familiar to everybody, right? So you are definitely not alone, okay? I'm going to talk a little bit about statistics. It's a very common mental disorder. Globally, there's a Q&A now. Let's see. Sound is fading out.
Oh, from the microphone? Can I move it a little bit, maybe? Okay, all right, I'll try my best. And I'm loud. Okay. All right. So like I said, you're not alone, right? More than 264 million people of all ages suffer from depression, around 40 million suffer from anxiety. It's important to notice that anxiety and depression are highly comorbid, meaning that they can both happen simultaneously. Depression is a leading cause of world disability, and women, unfortunately, are twice as likely or twice the risk of developing depression and anxiety when compared to men. So we are not alone. Let's see if I can keep going. I don't know. No, it's moving. Okay. So depression can unfortunately lead to suicide. It's close to 800,000 die by suicide each year. It's the second leading cause of death for those people ages of 15 to 29. There's a lot of effective treatments, but only 75 to 80% of those in low to middle income countries do not receive treatment. Why is that? There's just a lot of barriers to care. There's lack of accurate diagnosing, lack of professionals. Not many people want to be psychiatrists. Not many people want to be psychologists. It's a huge misunderstanding about what we do. And I think with that comes the inability of people to kind of motivate themselves to become psychiatrists or psychologists. And there's a lot of the snap out of it mentality. And I'm sure you have all had family members like kind of like you're having a face, you just need to snap out of it. Just like you, it came, it's going to go away. Patients are seen usually as potentially violent. A lot of patients that go get psychiatric help. And the reality is that psychiatric patients are at a higher risk to be victims of violence and being perpetrators. So of course, there's the stigma about getting help for mental health, right? And that leads to a delay from when you first experience symptoms to the point where you actually get help. And that can be anywhere from 8 to 10 years. So that's a long time for someone to be suffering in silence, right? With family members saying, snap out of it, it'll go away, it's nothing, you're just having a phase, right? Or someone feeling like they are just not right? Someone feels damaged. And then if you go get help, it's just kind of like reinforcing that personality. So what is stress? Stress doesn't have to be bad, right? Stress leads to a lot of body changes that require adjustment. It's a response, right? It's your body telling you that there's something that either needs to be addressed or something needs to be done. Stress is a normal part of life. We all experience stress. Like I said, stress is not always bad, right? We look for pervasiveness of symptoms, which means that you experience it every day. It becomes something that is too dysfunctional, right? Just like when you go to the hospital and you might have had a high blood sugar one day, it doesn't necessarily make you diabetic, right? So stress doesn't have to be a bad thing. Stress doesn't mean that you're depressed. Stress doesn't mean that you have an anxiety disorder. It might be an adaptive response to something that you're experiencing. People without stress never achieve deadlines, right? You have to have some kind of stress to achieve a deadline, right? Who, when they were in college, had a paper that it was for 2 weeks from now, and you just let it go. Nights before, you're under a lot of stress, and it gets you. So it doesn't have to be a bad thing. However, when it becomes overwhelming, it affects your daily functioning. It affects how you relate to your family. It affects how you work. That's when it's a signal that you probably should be looking for some help. So 9 signs and symptoms of depression in women, right? There's both psychological and physiological depression. Yeah. Oh, I don't know what happened. Okay.
And look at this. Hi, folks online. I don't know if you can hear us, but I'm going to try to fix the mic volume here. I mean, we are I'm not really sure what else I can do, but we will absolutely share the recording.
Oh, maybe that's it.
I don't know if that helps, so we will try. Let us know online if that's better, and I'm so sorry. And we will share the recording if for some reason the sound quality is not great. Thank you.
All right, so feeling depressed, losing interest in stuff that you usually enjoy, that's a huge sign of depression. Having low self-esteem, thinking about health, right, that's the ultimate sign that you absolutely need help. Experiencing appetite changes, sleeping abnormalities, and it could be either you're sleeping too much, not sleeping enough, and having low energy, moving more slowly or more quickly, and then having concentration problems or difficulty making decisions. Now, like I said, you might go someday with a blood sugar elevated enough that maybe you need to get help, or you go to your primary care provider. Doesn't necessarily mean that you have diabetes, right? Now, when these symptoms, you experience one of them, two of them in a 2-day period because you had a difficult time with something, it doesn't mean that you have a major depressive episode. A major depressive episode, you kind of think about it when someone is experiencing 5 or more of these symptoms day by day, every day for at least a 2-week time frame, right? And of course, what we look for in any psychiatric illness is that it causes dysfunction, meaning that you don't want to wake up to go to work, you don't want to cook for your family, you don't want to mow the lawn if that's something that you don't want to put on some makeup, you don't want to dress up. That's the times when someone probably will go like, hey, have you been okay? Like, I've noticed that you're not doing this, or you haven't showed up for these meetings, or so that's when it becomes a problem, right? Not necessarily when you experience 2 days, 2 symptoms, because you have experienced an acute stress, okay? So we look for 5 or more symptoms in a 2-week period in order for you to kind of say, I don't think things are going well and I might need to get help. So common types of depressive disorder, we have a major depressive disorder, we have persistent depressive disorder, in which depression is present for most days in a 2-year period. Then you have the bipolar depression that you might have heard about. That's when a patient experiences both episodes of depression and a mania, a period of what's called mania. Postpartum depression, that's something that is talked about a lot. The premenstrual dysphoria disorder, seasonal affective disorder, it's something that tends to happen more in countries or states that have the seasonal patterns, right? And I can say that definitely coming from Puerto Rico, my first fall and winter here was tough, right? Leaving work at 4 o'clock in the afternoon and it being pitch black was devastating. But of course, I think it's just a matter of adaptation, right? We're all very resilient human beings by nature, so it's just a matter of adapting. And then atypical depression, in which I'm still getting a lot of QAs. I don't know if it's related to the sound. Okay. Okay, no problem.
This is a test, obviously. Well, it's the first time that we're doing a lot of these things. Okay, so now can you hear me? I can speak loud. Okay, so physical symptoms of anxiety, moving on to anxiety. Anxiety, I think patients very much likely report as bodily symptoms compared to depression, when it's kind of like more that sense of not being able to make decisions, feeling sad all the time. Anxiety is perceived a lot more by patients in their bodies, right? They feel tense, they get belly pains, they get dizzy, they get the muscle tension, the blood pressure goes up, you might have to run to the bathroom because you might get nausea, diarrhea, and that's uncomfortable, right? But again, there's everyday kind of anxiety, and then there's the anxiety that is pervasive. You experience it every day, all day, and that's when you need to get help, right? Everyday anxiety related, oh, did I forget to pay this bill? And you kind of think about it on the way home. You get home, you're not ready to make dinner. You're still thinking about if you paid this bill, you paid the bill, and anxiety is gone, right? Now, there's a couple of different anxiety disorders. There's a generalized anxiety disorder, which accounts for 34% of the anxiety disorders. That's when you have like constant and really unsubstantiated worry about a couple of different things. You just can't seem to shake, even if you have addressed maybe what's worrying you, you still can't shake that tension off your body. And then you have panic disorders, phobias, PTSD, obsessive compulsive disorder, which account for the other anxiety disorders.
So this is, again, just a diagram of how to recognize anxiety. How do you experience it in yourself? The overthinking, the sweating, stomach issues, panic attacks, needing a lot of reassurance, trouble concentrating, trouble breathing, constant worrying, rapid heartbeat, headaches, definitely something that happens, and definitely the lack of sleep. I think anybody who ruminates and thinks about a lot of things all the time can't sleep. The brain can't just quiet, and the brain needs sleep. In order to heal, to recover from the daily activities, the daily thinking, the brain needs to heal. Just a quick diagram of medical conditions that can cause either symptoms that would make you think that you have anxiety or you have depression. Most common, hypothyroidism. As psychiatrists in the outpatient inpatient, every patient that gets admitted with depression, we want to make sure that they're not hypothyroid, that their vitamin levels are all where they need to be. Vitamin D is a huge one, and I think it comes with the lack of sunlight during the winter. That's why the seasonal affective disorder is a huge thing in more frigid climates that don't get enough sunlight. The vitamin D levels go down, and you need to be supplemented with vitamin D. So sometimes experiencing a mild depressive episode could be that your vitamin D level is very low. So it's important to see your primary care provider for that, to get a full workup and make sure that medically there's nothing going on that would lead to symptoms of depression or symptoms of anxiety. There's many things that kind of like are shared between both the depression and the anxiety. The restlessness, the excessive worrying are both things that can happen in both depression and anxiety. Like I said, they tend to happen together, depression and anxiety. They go hand in hand. Let's see. So why do we carry the anxiety and depression load, right? This is a part that we all kind of like want to know, why women are more likely to get depression or anxious. So in terms of lifestyle, unfortunately, women are more likely than men to live in poverty, be subject to discrimination, and be sexually and physically abused, unfortunately. Hormonal changes, I think that's a huge thing from puberty to menopause. We experience a lot of fluctuations in hormones throughout our different stages in life. There's a lot of studies that confirm that anxiety and depression often begin in periods of where there's a lot of more of the fluctuations. So meaning when you get your period for the first time, and then when you are heading to menopause. In terms of thinking habits, women are significantly, unfortunately, and a lot of things in medicine tend to affect more women than men, unfortunately. But women are significantly more inclined to just have negative emotions, engage in a lot of self-criticism, ruminate about problems when compared to men. And in terms of learned behavior, unfortunately, this is the society, right? As children, girls who are shy or anxious are more often reinforced for these behaviors. Boys that are shy and anxious might be shamed and punished, right? If you're quiet, you're a good girl, right? And that leads to just maybe keeping a lot of things inside that you're afraid to share, because if you keep quiet, you're a good girl, unfortunately, right? So it leads to making all of these young females to internalize a lot of problems and ruminate about fears and about stress. So we should all be familiar with this in this room. Depression and anxiety affect women during their estrogen producing years more often than men, or postmenopausal women. There's a huge link between estrogen and mood disruptions, like I said, that occurs during premenstrual syndrome, premenstrual dysphoric syndrome, and postpartum depression. So even though estrogen leads to increase in serotonin, which is sort of the happy neurotransmitter, they can't quite understand if estrogen leads to the creation of these serotonin receptors. Why is it that women during these episodes, during these periods, why is it that they experience such depressive episodes and anxiety? So they don't think it's the estrogen per se, they think it's the fluctuations. Like when you have your period, you go through a cycle, right? Where you ovulate, and I'm sure that many here have experienced, you know, the hearing, well, I'm PMSing, right? And I think that's a very famous phrase. And it's the fluctuations in hormones that lead to these ups and downs in moods and anxiety. So when do I get help? When you experience unrelenting hopelessness. I think hopelessness is one of those things that as you first experience it, it's one of those hallmark symptoms or signs of severe depression. When you are hopeless, when you don't feel like things are going to turn out okay for you, those are the times that you really should be worrying about yourself or someone else who you know that is experiencing hopelessness. Worthlessness, feelings of emptiness, like I said, 2 or more weeks of symptoms. Absolutely, if there's any thoughts of death or suicide, when you start isolating, people who are used to calling out sick a lot, I think you should check in on them and make sure everything is okay. And then when, unfortunately, patients resort to substance use, that kind of adds another layer of difficulty in treatment, but it's certainly something that we're very used to treating, and it's possible. I think that when someone gets to the substance use, it just makes it a little bit more complicated, but it's definitely something that can be addressed. We do it on a daily basis. Asking for help doesn't mean you're weak. It means that you're wise, that you're making the right decision for yourself and for your family, because depression, it not only affects the person who's experiencing it, affects everybody else around you. So I think a lot of people forget that depression is a biological illness. I think that there is this misconception that because you can't measure it with a lab, you can't see it in an MRI or a CT scan, that none of these things are real, but it is a biological illness based on neurotransmitters. And I did a little bit of there's a little diagram here. So you have the brain, these are 2 neurons. So that's the way the brain kind of communicates with itself. This is what a normal, this is called a synapse. This is where all the communication occurs with neurotransmitters. This is what it looks in a normal kind of brain. When you have depression, you don't have enough of those neurotransmitters, so the neurons are not communicating effectively, right? So medication, what does medication do? It allows for the neurotransmitters to stay in this space by not allowing the neurons to take it back, right? So you have more of the neurotransmitters, better communication between neurons, and improvement in the depression, okay? I put this in here. Why? Because I think it's crucial for someone to have a good therapist. In any of the board tests that you take when you're graduating from psychiatry, the answer, we used to joke, and even with residents, the answer is always medication plus therapy, and that is the winning combo. Unfortunately, it's one of those things that you have to kind of go around and find a good fit. Not everybody's a good fit. You could be an excellent therapist, but it's just a matter of fit with the patient. But definitely considering medication and therapy at the same time, it tends to be the winning combo. Doesn't mean you have to be on medication forever. It just means that you need to get that bump to kind of move from that, difficult space. And sometimes patients do very well with just therapy after a couple of months of medication. So other treatment modalities, electroconvulsive therapy. I'm trained and certified. I've been doing it for 5 years now. Very effective, very quick in terms of relieving symptoms. If you think about medications, when we meet with patients that are interested in taking medications, we do have to make the, have the discussion that medications usually take 4 to 6 weeks for the patient to kind of see a difference in how they're feeling. With ECT, in a matter of 3 weeks, 2-3 weeks, you should have 6 to 9 treatments of ECT. You should be experiencing up to 90% of relief in your symptoms. The only thing is that people are scared of it. I think it's because of the movies that we've seen in many years. It's a very safe treatment. The mortality rate is 0.001% per treatment per patient. So it's a very safe procedure. I think it's a matter of the knowledge that you're having a seizure that creates a lot of panic and fear. It requires general anesthesia. A lot of patients are very concerned about side effects. The most common of them being just a little bit of soreness, some headache, and the memory impairment is what I think kind of scares the patients a lot. I always tell them, you're not going to forget who you are. You're not going to forget who your children are. You might forget details about a movie that you've watched, but you're not going to forget crucial details about yourself, about your family. And these memories might come back, okay? It is a commitment. Patient needs to be committed. We do it 3 times per week at the beginning. You can't drive. It's a procedure that requires anesthesia, so you can't drive. There needs to be a committed family member and a committed patient for ECT. Transcranial magnetic stimulation, it's getting to be a little bit more, I think, famous nowadays because you don't need anesthesia, right? It's a, I'm sorry. You induce some magnetic pulses directed to the area of the brain that has to do with depression, which is the hippocampus. And it leads to a lot of improvement in symptoms as well. You need a little bit more of sessions to kind of start seeing a difference between, I would say, 20 to 30. But the benefit of it is that you can drive, there's no anesthesia involved, and it can be done in an outpatient setting. You don't have to be in a hospital. So I think patients really want this to work for them. Sometimes it's not insurance covered, so it can be very expensive for patients. ECT, it's covered by most insurance, if not all of them. Then ketamine, which I think everybody hears about a lot. Ketamine, everybody probably knows about it being a horse anesthetic is what it was kind of commonly used. It can be given via IV, an infusion. You have to be in the hospital for that. And then the FDA approved version of ketamine is the intranasal one. It was recently approved March of 2019, if I'm not mistaken. It really quickly reduces symptoms of depression and suicidality. The problem with it is that there's quick reemergence of symptoms if you don't keep up with the infusions or with the intranasal medication. So I think there's a lot more that needs to be studied with ketamine, but it's certainly promising. I think it's probably going to be the future of psychiatry, a lot of these new modalities in treatment, because the reality is that medication sometimes, like I said, takes 4 to 6 weeks to take any effect, and patients get frustrated. When you're feeling like that, you want a quick relief and find something that doesn't have too many side effects and you don't have to wait. This is just a table comparing, we have 10 minutes, okay. So in terms of cannabis, the American Psychiatric Association states that there's currently no scientific evidence to support the use of cannabis as an effective treatment for any psychiatric illness. So I just wanted to kind of highlight that because we do get a lot of patients that come to our clinics wanting the medical marijuana card. So it's not something that we are doing at Middlesex because the American Psychiatric Association really does not support the use of cannabis. So natural approaches, I think everybody has probably heard about St. John's words. Just want to point out that natural does not necessarily mean safe. There's a lot of medication interactions that happen with these natural medications. So it's just a matter of consulting with your psychiatrist or your primary care provider if you're interested in trying any of these. 5 natural things that you can do: exercise, eat healthy, sleep well, get some light up here, particularly during the winter. I know a lot of people like to travel to more warm places and bright places during the winter, not such a bad idea. How to help someone with depression: listen without judgment, encourage them to get the right kind of help, try to imagine what they're experiencing, get them some space to feel, encourage them to leave the house, stay active. Impact of social media, I don't think I have to say much about this. It's a recipe for disaster. Sometimes we compare each other to how others are doing, and that's sometimes it's just not the truth, right? People post whatever and it doesn't mean anything, but it just leads to a lot of comparison, which is never healthy. So shifting gears a little bit, I'm hoping that we can do this in 10 minutes. I think that we have all been struggling with this in the last couple months. To be honest, I never thought that in my medical career I would have had to deal with something like this. As a psychiatrist, a lot of people think, well, you don't deal with any of those things. Well, psychiatric patients generally don't get the best medical care. Why? Because they're usually not trusting of the medical providers, medical experts, so they don't reach out for help, right? So they do get very sick, and when they do, they need to be in the hospital. So we did have a lot of COVID patients that I needed to see on a daily basis. So it hit us hard too. And then of course, we have things like what happened to George Floyd, which was very unfortunate. That kind of makes us look at ourselves and how we think about things in society. So that has been also very difficult. So events tend to be more stressful or traumatic when they're unexpected, check, right? Many people die, check. They last a long time, check, right? The cause is unknown, check. It's meaningful, impacts a large area, check, right? So we're all experiencing a very stressful and traumatic events. I don't think we have to go through this, but physical, emotional, behavioral, cognitive stress reactions, anger, a lot of sadness, a lot of difficulty concentrating. I don't know about you all, but I don't think I've ever had these many nightmares in my life since, you know, COVID started. So it's tough for a lot of people. So there's a lot of fear of getting ill, getting separated from your family. If you do, by any chance, unfortunately get someone sick in the hospital, at the beginning of this, no one could visit a family member that was dying. So I think there's a lot of fear, not just getting sick, but losing someone who is sick. Fear of being socially excluded. You know, sometimes I go to places and they're telling me, well, have you ever been exposed to anybody who has COVID? And it's kind of like, well, you know, I work in a hospital. What am I supposed to say, right? Am I going to be excluded from something if I say yes? So there's a lot of fear of what adolescents nowadays call missing out, right? There's a lot of things that have been rescheduled, family meetings, family gatherings, birthdays, weddings, right? And like they were all saying at the beginning, we strive for connection. We want a human to be next to us, right? Even if they drive us crazy, we want humans next to us. We want that connection. So stressors specific to COVID, there's not an approved vaccine or treatment at this point. Risk of being infected, common symptoms like allergies, right? You sneeze nowadays and someone will give you the look, right? Is that a COVID sneeze or what is it, right? So symptoms just like allergies that are so prevalent during, you know, these times in the summer and spring, you can't sneeze nowadays, right? Let's see. Social isolation, I don't think we need to talk about that, right? It's devastating for a lot of people. Social people are struggling, can't go places, can't meet others. Like I said, we strive for that human connection, right? I think the fact that we keep getting inconsistent information, there's a lot of uncertainty. When is this going to end? And I have 5 minutes. Let's see. Okay. So in Minnesota, there was this thing called psychological first aid created, which was created by the Red Cross. And it's not necessarily mental health professionals. These were all volunteers that just wanted to make sure that patients, well, not patients, I keep talking about patients, but that citizens were using their coping skills. We all have coping skills. We love to find something that will keep us distracted. So these were not necessarily mental health professionals. These were just volunteers that got some training in a way to make sure that people were using their coping skills, to make sure that their basic needs were met. And that's the most important thing when there's a traumatic event, basic needs and going back to normal, right? Nowadays, the new normal, what does that mean? But going back to normal is crucial. First, basic needs and going back to normal as soon as possible is crucial when there's a traumatic event. Let's see, we talk a little bit about this. So let's see. So shifting gears a bit, I wanted to bring this up because I think it's also important to talk about this. It's another traumatic event, another stressful time that the nation is kind of experiencing, and it has led to a lot of talks, a lot of very productive meetings, a lot of committees being created, and I want to say that, you know, at Middlesex, I think every department is doing something to kind of target this, because it's, and the other day I was in a meeting with residents, and I kind of went to the meeting not really expecting that the residents were going to be vocal about it, and I was just taken aback by the level of maturity that they expressed and how much they want to be involved in the community with committees that are really, really trying to make a difference. So these are all kind of like my own thoughts that I've collected, and I've discussed with several family members, with some colleagues, but I think there's sometimes in the community feelings of guilt. You know, people question, have I contributed to this with my thoughts, with my actions? Have I contributed to this with my silence or my inaction? Right? I think there's a lot of mixed emotions. There's a lot of anger. There's a lot of very confused people. There's a lot of sad people. And I think there's the other aspect of it, which is the positive side of this, if there's any, is that it has led to many people getting inspired to get together, right? Like I said, like the committees that are being created, the residents are getting together. There's been a lot of talk. I think I've probably been in like weekly, if not bi-weekly, Zoom calls to discuss this and to see how we can become allies, right? The thought of me that you know, we have to judge and do things based on the color of the skin of someone, to me is just mind-boggling, right? Why can't we just like each other the way we are, right? So I think there's a lot of fear what's to come. You know, is it safe for my friend to go out there? Is it for my family member, for my nephew, for my whoever, right? Whoever you know that is close to you that might not feel safe in the community, and how we can address that. The sociopolitical atmosphere is so tense. I think it has a lot of people very nervous about what's going to happen in the next couple months. I think the images of brutality, the protests turning violent, have been heartbreaking, and has led to a lot of people having nightmares, a lot of people having triggering memories of maybe something that they might have experienced in the past in terms of racism, rejection, and there's a lot of increasing sadness, right, with the fact that something like this had to happen for us to have this kind of conversation. So I think that it's important to give yourself some space to think about how we can move forward in terms of you know, being safe, being allies, doing as much as you can to jump on this movement, because I think it's one of those things that I told the residents. I said, sometimes things have happened in the past and we have this conversation and it kind of falls through the cracks. We don't talk about it again. But this is just, has been week after week after week. I've been joining meetings, and it's just very inspiring to me that a lot of people want to address this. So give yourself some grace. I like to say that to everybody. Give yourself some grace. Praise yourself for what you do on a daily basis, because in 2020, I think getting through a day is by itself a huge accomplishment, which you know, with everything that we've been experiencing. Like I used to tell my husband at the beginning of this, you know, going to work every day was something different, you know, with the mask, with the PPE, so getting through each day is, with having had to change your routines and your schedule, it's a huge accomplishment. So validate what you do and give yourself some grace, because I think it's important. The American Psychiatric Association condemns racism in all forms, and it calls for end to racial inequities in the United States. I just wanted to put that out there as well. We follow strong guidelines from the American Psychiatric Association. And this is something that I'm going to leave there for you guys to kind of go over. These are the personal stages of societal catastrophe, and kind of think about where you are, right? I think most of us are past that mistrust and denial, that the news are seen as too much, fake news, it's not applicable to my own reality. I think pretty much a lot of us are past that. I think a lot of people are past the fear and panic, you know, this need to be in the news all the time and hearing what's happening, and there's hoarding of items. I think, you know, the toilet paper, we all know how valuable it became at some point. So I think most of us are past that stage. There's a lot of coping and mending, I think, at this point. I don't think we're seeing as much news. At least myself, I just wait for breaking news to come to my phone. I'm not, you know, fanatically looking at news on a daily basis or every hour. Some of us are using humor, learning new skills for protection and survival, appreciation of what each other contribute to society and the environment that you're in, efforts to assist others in current struggles. So hopefully we can get to some maturity and balance right? And then resolution. But I'll leave that over there. You can go over it and kind of decide in which phase you're in and how you want to move to the next one. So we're done. I think that was a lot, very quick, but hopefully it was helpful. And I don't know if there's any way, let me see. Oh, sorry, there's 44 questions. Let me see. No, 44 participants. Okay. So if anybody wants to start with questions, I can start with this side and go like this. Any questions? Don't be shy. Okay. Oh, okay. It was a lot, very quick, but don't be shy. No? Yeah. So that's usually when it comes out of nowhere. That's when we call it a panic attack. Panic attacks tend to come out of nowhere, even if they wake you up. It tends to come and go with no particular trigger. There's treatment for that. Usually it's rooted in something that you might be thinking that you might not be aware of. Sometimes it's triggered by some trauma, some traumatic events that have happened in the past. I think the dreaming, most patients forget that they dream because they might just dream at the very beginning of the night, and then you don't typically recall those dreams. Sometimes dreams can lead to waking up in that state of panic, even if you're not aware of. Yeah. Are there any thoughts that are associated with the panic or no? And it's done. Yeah, those are typically panic attacks, even if they wake you up in the sleep. It doesn't happen throughout the day. Might be a dream that you're having or something. Yeah. All right, let me see if I figure out how to do that. There it is. Okay. Okay, so I see, okay, you had a question, sorry, and then I'll come to this. So I think that for adolescent, I'm sorry? So she asked if with the social media, we talked about how sometimes it can lead to worsening of anxiety or depression. If with the social media, I have seen a change with the adolescents. Did I get that right? So I think with adolescents, they're all media savvy. And I think they have loved the idea of doing Zoom for school. So I think it has taken away some of that socializing piece to the social media to kind of like see it more as a learning tool. We in our outpatient clinic, incredibly so, the patients that were doing the best with Zoom were the older population and the adolescents. People from like 35 to maybe 65 were struggling. They could not handle the whole Zoom. They didn't know how to use it. And then we had, in the emergency room, an 84-year-old who was perfectly maneuvering their phones. But the adolescents, I think it has worked really well. I have to say that we haven't seen in the emergency room as many adolescents as you would expect to see by the end of the school year, like we do every year. So I think it has to do with the fact that they're so savvy with media and internet stuff that they did really well. There was a lot of, I think the parents probably struggle a lot more. Definitely. I heard a lot about that. We saw a lot more parents than children in the emergency room related to that. But I think it worked very well for adolescents. Mm-hmm. No, we haven't seen that increasing. She asked if with the protection of the internet, the kids were getting maybe like meaner. We know that there's a lot of bullying that happens. It happens through social media as well, but we have to say that we haven't seen an increase in that, fortunately. So anybody else here? There's a couple there. Yeah. Mm-hmm. So I tend to use it as a first line. So she asked about melatonin. She saw in the slide that I had melatonin in the one with the herbal supplements. I tend to like it a lot. I use it for children, for older patients, for adults. The thing that a lot of people don't know is that melatonin, the physiological dose that you really need is like even under 1 milligram in studies. But of course, it's marketed up to 10 milligrams. And there's patients that I've had that the lower the dose, the better that they sleep. But then I have patients that need up to 10 or 15 milligrams. I tend to use it as a first resort. It's one of those things that I'm not afraid to use with other medications that we use for depression. You just have to make sure that the patient is not on blood thinners. A lot of these natural medications tend to interact with blood thinners. So that's one of the important medications that you need to consider. But it's important to start with a low dose, again, because the physiological dose is under 1 milligram. So I usually start with 1 milligram for patients and then recommend kind of increasing to 2, 5, 7, 10, and so forth. Anybody else before I go to the online? All right. So someone said, how do you make a supervisor understand that they are the root cause of your anxiety and depression? Wow. Okay. Well, well, it's one of those things that I think it's in any interpersonal interactions. I like to encourage patients to not say, well, you, right? You do this and you do that and you do this and you do that. I like to turn around into being kind of like, well, when these situations happen, I feel this way. It makes me feel this way. So it takes attention away from confronting someone saying, you're mean, or, you know, you say these things and you say those things and people are kind of talking about how mean you are, right? So turn it around and saying, when these situations happen, this is how I feel. And I feel like if things were done in this other way, it would help not only me, but other people who might be experiencing the same kind of reactions when we experience these situations without necessarily having to say, you are the cause, right? Let's see, as an HR manager, recently saw an employee struggle to find resources during COVID to find IOP meetings. So IOP is one of our levels of care. It's an intensive outpatient program. It runs 3 times a week at Middlesex, and you get to do groups, you do personal therapy, and then you get to meet with a psychiatrist. So it says again, as an HR manager, recently saw employees struggle to find resources during COVID to find IOP meetings to deal with bipolar depression and anxiety issues. Why is that? So, of course, unfortunately, during COVID times, the IOP and PHP, which is a partial hospital program, it's a step down from a hospitalization. Partial hospital program runs 5 days a week, so it's a little bit of more intense program. So, of course, those programs run based off of groups. Sometimes those groups can be 12, 14, 16 patients. So given our space, the space that we have at Middlesex for those groups, we had to do what was safest for not only patients, but for the staff, and turn that into a virtual. A lot of patients didn't like the virtual. I can't blame them. Like I said, there's nothing like person-to-person interaction. So I think it might have been a problem of not everybody had access to a computer or internet. I'm not sure that particular situation, why they had a problem to get to an appointment, but we can, if someone can send me an email, I can look into that and see what was the issue. So someone says, would you consider depression and anxiety to be a lifelong condition rather than an acute illness? Absolutely. So depression is a lifelong condition. So is anxiety. There's bad days, there's good days, right? And that's why it's called major depression. And then you have major depressive episodes. It's in episodes, right? Once you have an episode, you're more likely to get a second episode. Then when you have a second episode, you're up to like 50% more likely than the rest of the population to get a third episode. As you keep having episodes, the likelihood that you'll continue to have episodes is higher. So patients after a second, third episode, those are the patients that I will absolutely recommend they continue on medications for as long as they can, because the likelihood and what we've seen is that unfortunately, second, third, fourth episode of depression, it just comes back with a vengeance. You know, by the second, third, fourth episode is when unfortunately these patients start having suicide thoughts. So those are the patients that I will absolutely say you should be on medication for the rest of your life, or as long as you can tolerate it. Yeah. So someone is saying Calm Magnesium is a wonderful supplement that helps. Neurologists love it and got me off of Xanax. So yes, magnesium is one of those that helps patients settle when they're in bed. I've taken it myself. I'm a huge fan of self-disclosures when it helps some other people. So I've taken it myself. There's really not many side effects, and it's really helpful in settling when patients are in bed. So it's one of those things, again, anything that you buy over the counter, just discuss it with your primary care provider or your psychiatrist or any mental health professional or any medical professional that you're seeing. Yeah. Okay. Someone just posted something. Oh, I think it's a person. Oh, they're mentioning patient's name. Okay, no.
You can close that window.
Okay.
Thank you.
They can email me.
Okay.
Okay.
Thank you so much.
All right. You're welcome. Thank you. And please. Okay.
So we're going to wrap up the webinar here. And thank you so much for bearing with us. We finally figured out that the feedback from our local microphone was messing up the sound online. So thank you so much for telling us that we were having a problem, and I think we fixed it. So thank you so much. Just a few parting words for you. If you are interested or need help or have somebody that you'd like to refer, this is the phone number and the web address for our Center for Behavioral Health. And we will send that out in an email so that you don't have to scramble and write that down. Next up, we have a survey. It's going to be online this time for everybody. We will email it out, but feel free to, have it in your packet. But we really do want your feedback. It's very short. So we really appreciate that, particularly with this new format. I'd love to hear what you think. And then finally, we appreciate all of the members who have made this work possible. We get to come together and learn together, and your donations every year help us fund some important projects. So for those of you who don't know or need a refresher, membership starts at $100 or more per year. It's renewable annually, and you get invited to 3 health talks. Perhaps there'll be a time when we can return to meals together and sharing a glass of wine. I do hope so soon. And for you all to bring a guest as well. 100% of your donation goes to the project that you choose among the ones that we've selected for the year. You're welcome to go online to check out more about this or contact me personally. I'm Sarah Moore. So thank you again so much for those of you who came online and those of you who came in person, and have a lovely evening. Good night.